Hello, I'm Donald Macaulay and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine around the world. Today we're in Scotland and I'm talking to Margaret McCartney. Tell me about your current role and how you got there.
I'm a GP in Glasgow. I'm currently working half-time. I'm just been appointed actually senior lecturer at the University of St Andrews, which is great and will hopefully enable me to push forward with some research and some constructive work around the things that I'm interested in. And I do freelance writing and broadcasting, and I'm also a director of Byra's Place, which is a rape and sexual assault centre in Edinburgh.
Well, now, what really struck me was when I saw some of your work, looking at lots of the things we did in general practice that we thought were right, but have shown actually not to have evidence or in fact to be harmful. Tell us a little bit about those.
Yeah, so actually the reason why I became interested in this is because not long after I was married, my husband was doing a systematic review into renal replacement therapy, and he casually mentioned, breast cancer screening, probably doesn't really work. There's not much evidence around it. And I was thinking, that can't be right. No one's told me about that. And I did a bit of reading. I was a junior doctor at the time. These thoughts were kind of percolating around my mind. And then when I was on maternity leave for the first time, there was an article that was published in the Independent newspaper saying basically that cancer screening or just whole body screening was the way to go. It was ridiculous that the NHS didn't organise this for you. Everyone should have a full body CT scan once a year to pick up problems early. And by that time, I'd kind of a fair idea that screening and early diagnosis was all kind of much more complicated than it might first appear. And I was so cross that the newspaper had printed that with really no accountability that I ended up writing about it and then continuing writing about it after that. And I think what really scares me in medicine is that you can be thinking you're doing the right thing. You can have moral integrity. You can have passion to, for your vocation or for your career, you can want to help people, and you can still absolutely screw up. And it's a bit terrifying because it's not just about how clever you are or how much you've read. It can be that what you've read is wrong. What you've read doesn't apply to the patient that's there in front of you. The whole I suppose the whole industry that's brought you to the point where you think that this is the right thing to do for the patient might actually be inherently wrong from the very beginning. And I think we saw it even very recently. I was talking to someone earlier about chronic pain. I remember I was shopping in Glasgow a few years ago, and there was a stall outside Buchanan Galleries, a massive shopping centre, and it was a little stall, and they wanted people to come along and talk about their pain, and it was quite clear there were two very nice ladies at the stall. They had leaflets, and it was, take this leaflet to your GP if you've got chronic pain, ask for better painkillers for nerve type pain. There was long lists of all the symptoms you could have, and quite clearly they were the gambit was there for pregabalin, gabapentin. Sorry, it's my dog. Really trying to promote patients to go to their doctors to get this prescribed. And of course, we now know that, well, we would have known then had we asked the right questions. It's got lots of side effects. It has addictive qualities. It has withdrawal effects. It has a street value. It's not that effective for many, many people. And yet that information wasn't being presented to people at the same time as they were being told to go and see your doctor because there are better alternatives for your pain.
Well, you've said lots of things there that I'd really like to follow up on, some really interesting things. The first one was in relation to screening, because I've seen you write about the patient paradox.
Yeah.
I guess screening in a sense does create patients where there weren't patients, and there are patients who need help and don't get help.
Yeah.
Tell us about that.
Yeah, so this is a book that I wrote, and it's probably quite out of date now, about a decade ago, called The Patient Paradox. And really what my frustration was that in healthcare, and the person who really started this off was, of course, Julian Tudor Hart, talking about the inverse care law. And to me, it just seemed to be a few steps further along we got from that, because not only did you have the inverse care law where the people at greatest need of help didn't get it, what you were now having was that people at the greatest need of healthcare still didn't get it, but at the same time we're making people who are not going to be advantaged by medical intervention, we're making them into patients to their disadvantage, and also to the health services disadvantage as a whole, because it's a limited resource. If you don't make that cake bigger, people are going to get less of it. And of course, people that get less of it are the people that could have benefited the most to start off with. So it's a double whammy. You disadvantage everybody.
Now, you also spoke about the pharma industry, and creating the false hope of new drugs. And I think one of the things you spoke about was Alzheimer's disease and the false hope in Alzheimer's disease.
Yeah, so my friend and colleague Deborah Cohen and I, we've just recently done a kind of large investigative piece about the kind of new immunomodulator drugs for Alzheimer's disease that are going to be assessed by the National Institute for Health and Care Excellence this year. And really what you see, particularly in America, is this huge push for these drugs, you know, people saying it'll, you know, making all sorts of claims that I think are almost entirely based on wishful thinking. I think it'd be very hard to read the claims from, you know, and it's very much, it's not just the claims from the companies themselves, but the companies, of course, they fund charities, they fund organisations, they fund stuff that's going to present a more emotive picture, I think, to policymakers and funders. And it's very hard to let people down and to say, actually, these drugs are not as effective as this picture would have it. These drugs are very unlikely to have a massive benefit and allow people to live at home for longer or to continue driving, you know, or whatever. So it's very difficult when you come along with this kind of bad news because nobody wants to hear it. I don't want to hear it. I would much rather be saying to my patients, we need to get you on this drug, it'll be fantastic. But that's unfair. And not only is it unfair to that person and their family, it also means that you are assuming that this works. Therefore, that's the right pathway to go down with your drug interventions. And also then maybe you don't have to worry about research in other areas that actually might have been more beneficial had you went down that route. So you're kind of biasing the whole system towards drugs that don't particularly work, but also away from things that had they been better investigated and invested in might have worked.
You've talked about some of the other myths about drinking more water, and you've challenged homeopathy. I mean, how do we prevent these myths being taken at face value?
Yeah, I mean, I suppose there's regulation, you know, so I suppose it depends what is your claim that you're making, you know, and who's making that claim. So if you're making a claim as a regulated professional, you know, you shouldn't be allowed to because there's lots of research evidence saying that healthcare professionals are trusted more than the average person. Therefore, I think there should be a higher standard. And you get this particularly where there's financial conflicts involved when people are selling something, either they're selling private appointments, they're selling, you know, supplements, they're selling they're making money directly out of the claim that they're making and their claim's not valid. So I think the regulators should take an interest in that, but we know that they don't. You know, I've certainly tried over the years to get regulators to become interested in this kind of stuff, and I've really had very little helpful response from them. But then there's also where people are making the claims. So if they're making it on an advertising platform of some description, there should be some kind of regulation about that. But the thing I find most invidious is when people are making claims in media through a conduit, through a journalist, through someone like that. And there's a bit of truth in what they're saying, you know, there might be something in that, but it just goes well beyond the evidence. And you don't get a chance to reply to that. You don't get a chance to discuss it or debate it. You know, just now in the UK, we've got this massive poster campaign asking from one of the prostate cancer charities, basically saying that all men over 50, and I think black men over the age of 45, I think is what their algorithm says, should speak to their GP about prostate cancer screening. And we know that this is, you know, extraordinarily contentious, very difficult, certainly is not recommended by the UK National Screening Committee, who make independent judgments about this. And actually they say that GPs shouldn't raise PSA screening with asymptomatic men because it's not best evidenced. So where do you go with that? You know, so they're making this claim to say you should do this. That automatically means that general practice does not have the capacity to do other stuff. But it's entirely, you know, there's nobody that I can get to kind of try and come to some kind of middle ground or some kind of, you know, they should be entitled to say what they want. It's not, you know, freedom of speech is, you know, is what I'm here for. But equally, they shouldn't be allowed to give partial information to men. You know, they should be, if they want to say that, they should also be saying, but this is not recommended by the UK National Screening Committee, who are independent. This is not recommended by the NHS as a whole. But men are not getting that information. So they're going to see their GP then, and then it becomes my job to say, well, absolutely, you can have a test if you can, you know, if you wish to give informed consent to it. But we really need to go through that first of all. You know, there's other information that I think you should have before you make that choice. I'm never going to refuse a man, but equally, I think it becomes very difficult for GPs when we're immediately put into this position where we're having to give the rest of the information that somebody didn't come in with.
Yeah, so up against it a little bit with the pharma industry, but also with these various lobby groups. I suppose many of them are charities. But doctors themselves aren't immune to these problems. You've suggested that doctors should have a declaration of conflict of interest as well.
Yeah, yeah. Although I have to say, I've kind of my thinking on this has probably progressed and changed a bit. So, probably about 10 years ago or so, I still do believe that doctors should make a declaration of their interests, absolutely, which means that you should be open and transparent about money you're taking, for example, from pharma, from tech, from industry. You should say where you're getting your money from, so that it's on the public record and so that that can be managed. The problem is that I think I was, and I think probably many organizations were relying on this idea that if you make a statement of your conflicts, that's the management. And actually, that's not the management. All you've done is you've said what your conflicts are. And I think the inference in many organizations has been that if you make that declaration, everyone else will somehow treat the information you prospectively then give with the knowledge that you have that conflict. But actually, we have lots of very conflicting research about what people think about that. There's all these phenomena that happen. For example, people feel that sometimes when they make a declaration, it kind of absolves them. So they don't have to worry so much about it anymore because they've been honest. There's other research that says that when people hear a declaration of interest being made, they may think that that person is more honest and therefore more trustworthy. And yet we have no evidence that that is the case. The research that we did at the University of St Andrews, we asked people what they thought about declarations of interest. And first of all, they couldn't find them, even for kind of very famous doctors who were giving advice in the public domain. They couldn't locate these declarations. And these were people that had made declarations and they were kind of opaque. And then when they found the declarations and when they looked at them, they didn't know really what to make of it or how that information should be recorded. And that was similar for both professionals and for lay people. So we've basically got a situation where people think that they're being great and honest. And yes, I would absolutely encourage transparency, yes. But the question is then, what do you do with that information? And I would argue that we're allowing people to stay in the room with a conflict of interest when the correct management would have been to declare it and leave, because you shouldn't be allowed to influence a conversation where you have a conflict. So we're allowing these conflicts to be managed rather than to be excluded.
Now, let me take you back a little bit, because you talked about the pressure on general practice trying to do things that are encouraged to the deficit of other care for general practice. Now, that's a big problem, and general practice is under huge pressure in many, many different countries. So finally, what do you think the future is for general practice?
So this depends on what day you ask me, okay? Because I am inconsistent. I honestly think that general practice is the best job in the world. And when I have a good day at work, and almost all my days have got elements of being a good day at work, it is joyful. It is fantastic to know your patients over a long period of time and their families and your colleagues and the great people I get to work with. You know, it is brilliant. But also it's terrifying because we see every day the absolute fragmentation. You know, I spend so much of my time apologising to people or telling them to complain to their MP about waiting lists. People who would never have imagined going privately for something have ended up using their life savings to get a hip replacement on the basis that they think they'll be dead in 10 years and they don't want to wait half of that time to come up the list to get their hip replaced. We see the fragmentation in general practice as well, when people, you know, for whatever reason, and, you know, access is an issue in general practice, when they go to a private provider and then they get, I would say, not always the same type of information they would get from a GP in the NHS. And they may be recommended to have test treatments or interventions that I wouldn't have recommended. It wouldn't be within my health board recommendations, for example. So there's lots of gaps. Some of those gaps are how can I describe it? Some of those gaps are ones that are created by industry, by pharma, by I think people prioritizing access over seeing the same people again and again, like continuity of care. Some of that might be people's choice, but some of that I think is really the government, you know, running general practice into the ground. This idea that general practice is a series of transactions and anyone can fill in, you know, and anyone can, you know, that things are simple, you know, either you've got a UTI or you don't, you've got a sore throat or you don't, you know, everything's split into little bits. And I think that's really bad for holistic patient care, while at the same time we're still doing loads of stuff that's a complete waste of time, so much bureaucracy, paperwork, IT that doesn't work properly, systems that aren't joined up between primary and secondary care. There is so much that we could do to make our job more efficient. And yet what keeps seeming to happen is that our core job, which is that of seeing patients, is getting taken away from us, and instead our time is being filled up with pointless, inane bureaucracy instead. And I'm so angry about that, because that is a position of will, you know, that could get sorted out if people wanted it to. And I just don't think that the momentum or the will is there within central government to preserve general practice for what it is and for what it could be.
Margaret, it's been a pleasure talking to you. I'm afraid so many people share your frustration and anger at what's happening in general practice, and it's great to have people like you fighting for it all along. Thank you very much indeed. It's been a pleasure
Thank you
talking.
for having me, Donald. Thank you.